All right, guys, we're back and we're on to chapter 7. So remember, chapter 6 will be up first, of course. And so, like I said in the previous video, your next just regular test, which will be your last lecture test before your final, will be on chapter 6 and 7, and that's on the tentative course calendar that you have that we were following before the COVID-19 shutdown. And if you'll notice on that tentative course calendar, it does not show another test for chapter 8. It shows you reading chapter 8, it shows me lecturing chapter 8, but it doesn't show the test because it's difficult to get all this in. There's just no way to have a because when we're in the classroom, I like it when you guys, if you will, ask questions, and I like to go through the reviews, and it takes a little bit longer, and usually we just run out of time before we can get enough time in to do chapter 8. Having said that, like I said, chapter 6 is already up. This is going to be chapter 7. You should be following along in your textbook, filling out your study guides, and studying for that next test. And then I will also sometime very soon, chapter 8 will go up as well. And the only difference is you need to read chapter 8 in your textbook. You need to watch the video that I'll put up with the slides for chapter 8. And you need to fill out the study guide for chapter 8 and study it, but you'll only be responsible for that on the final. There will be some questions from chapter 8 on the final. Okay, but you won't have a specific another test for chapter 8. It'll only be on the final. So anyway, just wanted to make that clear to you guys. So immunology is what we're talking about in chapter 7, which starts on page 180 in your textbook. So we're going to move past this because we're not in class and we don't need to do any of that. And I'm going to just quickly go through these slides. And remember, pause them. This is a great way to study, guys. This is a great way for you to sit here and make sure that you're getting this knowledge down and you can answer these questions so you can be successful on your test. So make sure you pause them, get out a piece of paper, and just see if you're getting all this stuff right, okay? Like I said, that's a really good review for chapter 6. It would help you to go through those and just make sure that you can answer them. Here's our objectives. Our objectives are also listed on page 180 in our textbook. I'm not going to sit here and read each one of these to you guys because, you guys can read and that's boring anyway. It's boring enough listening to me talk with these slides and not being in the classroom, but I'm not going to read those to you. But make sure you read them because these are the things we want to learn. This is what we're going to go over and you guys are going to learn. Also remember on the bottom of page 180 and 181 is our key terms. And there's a lot more key terms here than there are in your study guides. But as a medical assistant, a lab assistant, like I've said before, not only do you guys need to learn this for your test here in these classes, for any type of certification or registry exam that you have to take, but also if you're going to continue your education in the healthcare field, this is stuff you just need to know. So it's going to help you. So again, these are the key terms. Like I said, there's a lot more in 180, 181, but these are the key terms that we're going to talk about, you know. And what is the clumping together of blood cells or latex beads caused by antibodies adhering to their antigens called? Agglutination, right? So I'm not going to read every one of these, but you need to know these for the test. You need to know these for any type of certification you have. This is just in healthcare. You need to understand what these things mean. And remember, the reason I put these key terms at the beginning, and the reason that they're at the beginning of Chapter 7 on 180 and 181, and the reason medical terminology is such an important class in healthcare is because learning these terms and what they mean are going to help you be more successful as we go through this chapter, okay? Okay. So covering fundamental concepts, just an overview of immunology. Okay, so the immune system, okay, is the defense system that protects the human body against invading pathogens, toxins, allergens, and cancer cells, right? Also other things like parasites and funguses and viruses, right? So when the body is under attack by any of these invaders, it has the full arsenal of defense to destroy the invader, as well as protect itself from future attacks. A key ingredient in their defense mechanism is the body's production of antibodies. And I know y'all have heard, you've probably been following the news talking about COVID-19 and talking about antibody testing. Antibody testing is vitally important because that's how we know you've been exposed to the virus or the bacteria and that you've built up an immunity to it. So that the next time you come in contact with that, your body will have some way to fight that off. Now, usually the problem with viruses, that's why influenza, the cold is such a problem, is because they can mutate and change, and it makes it more difficult for your body to be able to recognize it as what it is and mount its defense. So let's break these down, antigens into antibodies, right? Because they're a lot alike, and it's like glucagon and glycogen. You know, it's trying to figure out which one's the hormone, which one's the storage of sugar. Here with the antibody and antigen, it's the same thing. So let's start with the antigen, okay? So antigen is a substance, okay? Now, that's the thing we're talking about. So COVID-19 would be the antigen, okay? A cancer, a bacteria, a parasite, a toxin. These are all things that are foreign to your body, okay? So that is what the antigen is. And then the antibody or immunoglobulin, which is immunoglobulins are produced specifically to destroy foreign invaders, okay? So they're a protein produced after the body detects the presence of that antigen. Okay, this is a nice little picture of kind of how they work together, right? So how does this work? So they're specific, okay, for each antigen. And in other words, you can't come in contact with the antigen for influenza and then build up an immunity to COVID-19. It doesn't work that way, okay? So you have to have that antigen come in, and then you build up a very specific antibody to that very specific antigen, right? So once they are specific for that antigen, and then you have come in contact with it and you built that antibody up, they attack the antigen by forming that antigen-antibody complex and destroy or render the invader harmless by agglutination, which is clumping, or lysing, which is destroying it, right? So it's all lock and a key. You see that antigen there that's on the surface of that cell right there, okay? Let's see here. Right there. So you see that antigen that's on there, right? It's on there. And then the antibody comes on and attaches it to it, and it either causes agglutination or it causes destruction by lysis. But the point is, it builds that complex of the two together, and they clump up. Okay, so a lot of testing we do, even in blood bank, is we'll put a drop of blood, and then we'll drop that antigen down in there, and if it clumps up, then we know that, you know, there's a reaction there, right? So here's some specific homework for you guys, and remember, we always write this in our packet that you would be sitting there in class writing as we were going through these slides. So you want to describe in your own words how antibodies work to protect our bodies from foreign invaders like viruses, bacteria, cancer cells, and etc. And you can see as a healthcare professional why it's vitally important for you to understand how antibodies work, so that when you're out there, you understand how all this is going on. So just make sure you're able to write this down, and make sure that your answer contains something like this: that antibodies are specific to antigens, the substance of the body views as foreign, right? And antibodies attach to and try to destroy these antigens. That's also okay. So what is an antigen? Okay, so this is one of those times, right, where we're trying to see if we're absorbing this stuff, all right? So make sure you pause this and write down what an antigen is. So we know that the bacteria, virus, cancer cells, pollen that's floating around, those things are foreign to our body, right? So they come into our body. We may get sneezing, watery eyes. We may get an infection of some sort. And then we build up some defense to this antigen that we've come in contact with, right? So what is the antibody part of this? That's the substance produced by our immune system, right? That's our defense mechanism, so that the next time we see this antigen, we can destroy this specific antigen. Now, we know that this works in a lot of cases, and we know that it doesn't work absolutely, but it is a really good, effective way. And that's why we want to make sure that we get our vaccinations, and when we're fortunate enough for the COVID-19 vaccination to come out, that we all get that vaccination, so that will help our immune system to be able to fight off these types of viruses and bacteria. So some examples of an antibody. Remember, the antibody against a specific bacteria or virus or allergen. It can't just build up and then work against multiple different ones. So if we were in class, we'd do a little role playing. We'd have two volunteers, one to be an antigen. What kind do you want her to be, or he to be, or will be an antibody? Okay. And then we would play this out, but make sure that, you know, that's just trying to move things around in the classroom, but make sure that you really are understanding the roles with the antigens and the antibodies. Okay, so what is the name of the section of the lab that does antigen antibody testing? That's immunology or serology. Okay, immunology comes from immunoglobulins. Serology comes from serum, because antibodies are found in the serum. So here's one of our case studies. So I want y'all to pause this. I want you to read over this case study. And then as I move through, be able to answer these questions. We're still talking, we're still giving that basic overview of immunology, right? What is vaccination or immunization, right? Okay, so the process of injecting harmless or killed microorganisms into the body to induce immunity, which is antibody production, right, against possible pathogens. We have advanced in medicine, we have advanced as a race, human race, as a society, and there's no reason that you should have to get chickenpox to then build up an immunity to chickenpox, okay? And there's too many pathogens out there that are lethal, or if they don't kill you, they can cause lasting effects. So to reduce the chance of you being harmed, you having to go through a horrible illness, and possibly even you dying, we do all we can to come up with vaccinations and immunizations so that you can be injected with a harmless, okay, or killed microorganism to force your body to produce that immunity so that when you do come in contact with chickenpox or smallpox or measles or rubella, you already have that immunity. You don't have to go through the disease process to build it, okay? And we know that immunization makes the body produce antibodies against the substance in the vaccination, okay? For example, if killed flu germs were injected, the person would form immunity or antibodies against the flu. Now, I know you're saying, well, every year we get the flu vaccine and it doesn't work. Because again, and that's one of our fears, that's why that we should always listen to the scientists and not the politicians, okay? We need to listen to the scientists because that's an issue with viruses. They can mutate, they can change. And so when I said it's specific, that antibody was specifically made to the makeup of that particular strain of the flu. If next year it mutates and the strain is somewhat different, then we don't have an immunity to that. And they do the best they can to try to guess at what flu virus is going to be the one that's the most. And when we get that right, that's why we have those flu seasons that are much less. And when we unfortunately don't get it right, then we see more deaths from the flu. But this is why. But that still doesn't change the fact that we need to get our vaccinations and immunizations done. It's vitally important. We need that herd immunity, okay? So what is an autoimmune disease? You know, I talked to y'all earlier back in chapter 6, and I just brought it up a second ago about us attacking those cells inside our pancreas. So an immune disease is one in which the body produces antibodies that attack our own body tissues or self-antigens. So talking about our defense, you know, these are things that we have in our body. Remember, guys, chapter 7 starts on page 180, 181 in the textbook. There's some great pictures, great information. Please make sure you read along, okay? So that first line of defense, right? That's our natural barriers, right? The overall immune process that occurs as the body protects itself is viewed as 3 lines of defense, okay? So the first line of defense stops invaders from entering or growing on the body. The skin and mucous membranes serve as anatomical barriers to prevent the entry of pathogens into the body. Okay? You know, like the little hairs on the inside of your nose, the little hairs and the mucus on the inside, lines the inside of your nose, the stomach acid inside your body. Okay? These are all things, okay, that help us. And these natural barriers, these are non-specific natural barriers that just their job is to stop invaders from ever getting in to begin with, okay? Your skin is one of those things, right? So you want to give 3 examples of how the first line of defense works. Okay, skin and mucous membranes, they secrete chemicals that maintain a acid pH of 5.6. Okay, and when we go forward, we talk about the acidity of our stomach acid, right? This discourages the growth of pathogenic bacteria while allowing the growth of our normal flora, right? And these words in blue, mucous membranes, which those are those thin sheets of tissue lining the internal cavities and canals. In normal flora is that harmless microorganisms that normally inhabit the skin and mucous membranes. They inhibit the growth of those pathogens. In the respiratory tract, the mucous membranes contain mucus, which entraps foreign organisms. Coughing and sneezing helps move the foreign organism out of the body, right? We sneeze and we get that body out of there. That's why it's so important to sneeze into your elbow and make sure you're not sneezing out into just the open, right? Because that sneeze produces droplets and airborne stuff that can go out and then land on surfaces or get in somebody's face. And that's how we spread the common cold, the flu, and the COVID-19 virus, right? So here's another one of our case studies. So make sure right now you pause this, read through it, and then we'll move through the questions and make sure you're able to answer these questions properly. Okay, like we talked about that there was 3 lines of defense, and we talked about that first line of defense, and you can see this on page 182, 183 in your textbook. We talked about those natural barriers. Now we're going to move on to that second line of defense, which is non-specific internal response. Okay? That internal non-specific response to all invaders that have passed the natural barriers, right? They got past that natural barrier somehow, cutting your skin or something like that, and they entered the body. When invaders break through the barriers, the body quickly responds by sending phagocytes, cells capable of engulfing, ingesting, and destroying pathogens and cellular debris, right? So the nonspecific internal response that occurs when invaders pass the first line of defense, it generally seen within the first 12 hours of that infection in your second line of defense. So these are 3 examples of how the second line of defense works. We have WBCs, right, that go out there and they engulf or destroy the invader. We have neutrophils, and they engulf and ingest the invader by phagocytosis. We're talking about those phagocytes, right? We have monocytes that leave the bloodstream, become macrophages in the tissue, and they ingest the invader by phagocytosis. And then we have special lymphocytes called natural killer cells, or T8 cells. They attack and destroy the body's infected cells and cancer cells in a non-specific way. So you're hearing words there, right? Specific. This antibody is specifically made to destroy this antigen, and now we're talking about some non-specific ways in which we have defense mechanisms, right? And those natural killer cells are a special type of lymphocyte, right? And they sent to the scene of the invasion to attack and destroy the body's infected cells and cancer cells in that non-specific way, right? And protective proteins such as interferons and complement proteins also play an important role at the site of invasion, okay? So right here, let's pause this and think it through. You want to name the 3 white blood cells involved in the second line of defense. Okay, so still talking about our second line of defense, which is a non-specific internal response. Remember that first line of defense was natural barriers. It tries to keep the foreign invader from ever getting inside our body. But now we're talking about what happens when that doesn't work and we get that in to our body, right? And like I told y'all, we have those protective proteins, interferon, right? It's a protein secreted by the infected cells to prevent their further replication and the spread of the infection into neighboring cells. So this is that cell itself producing a protein that hopefully can cause it not to be able to continue to jump to cell and replicate, right? Interferon interferes with the spread of infection. That's a good study tip. And then we talked about complement proteins, right? They're proteins that further stimulate phagocytosis and inflammation. And remember, inflammation is a reaction of the body to the tissue injury or invasion by that infectious agent. And they're capable of destroying bacteria. Complement proteins swarm over a bacterium and punch holes in its membrane, causing it to fill with fluid and lyse or explode, right? So right here, another one of these slides. So pause this right now and see if you can answer these questions. Okay, so on to our third line of defense, which is still, we're still on our second line of defense, and it's still talking about non-specific internal responses, right? And I mentioned inflammation, right? You know, there's a lot of things that, like I talked about the good carbs and the bad carbs, and carbs aren't the devil, and there's good fats and bad fats. In most things in life, there's good and bad. We got to find that happy medium, right? So the inflammatory response is initiated once we have this foreign invader, right? Now, just like if you get a thorn in your finger, the same thing happens, right? Or an infection, right? You get cut and there's an infection there. It's a similar process to that. If you cut yourself and it gets infected right there, you'll have, if you put your hand on that area, there'll be some heat. It starts to turn red around there. It may swell up and it hurts, right? Histamines. These are things that are released by those injured cells, causing the dilation of your blood vessels. This is just you're trying your best to ward this off, right? You have increased blood flow to the affected area, which results in your redness and your heat. You're trying to get as many cells to that area to fix it and to defeat it as humanly possible, right? Fluids in the plasma leak into the tissue because of the increased permeability of the vessels, and that causes a lot of that pain and swelling. Now, most of the time you hear about inflammation, it's not good, right? You don't want a lot of inflammation in your body. It's not good for you, but a very temporary response that immediately goes to that, and with the help of everything else it gets rid of, is okay. It's one of our body's amazing ways to heal itself, along with like a fever. A low fever, your body increasing its temperature is a way to try to help you, right? But we wouldn't want an extremely high fever for long periods of time. So you got to find a happy medium and understand a lot of this stuff is your body's response to the infection, and it's a way your body is working with other things inside your body to actually heal itself. So again, here's one of our slides. Please pause this one and make sure you're getting out that piece of paper and you're going through it and making sure that you can answer these questions appropriately. Again, if you have any comments, questions, or concerns, if stuff isn't making sense to you, please, please, please reach out to me. I'll be glad to help you. So, and again, here's one of our case studies. Okay, so make sure you read through this and look at all of it. So we're giving an age, right? This is a male, 51 years old, right? Comes into the doctor. He's got a high fever, a headache, a sore throat, coughing, sneezing, body aches, and a running nose. Okay, that could be a lot of things, right? That could be a lot of things. So the doctor ordered a CBC, which is great. That is what we want to do, because we want to see what's going on when their complete blood count, because it could tell us, is this a bacterial infection? Is it a viral infection? What is it, right? So the results show a very low WBC count, right? Overall low WBC count and an increased lymphocytes on that differential, right? So what do you think the diagnosis will be? Viral, right? Because of the low WBC and the increase in the lymphocytes, like something like the flu will be a viral infection. Okay, so again, name the 3 WBCs that will play a role in the second line of defense. Our neutrophils, our monocytes, and our lymphocytes, right? So name the 2 protective proteins that will play a role in the second line of defense. That interferon and complement protein, right? And what is the name of the response in the second line of defense that causes heat, redness, swelling, and pain? Inflammation. Is it specific or non-specific? Non-specific, right? Only the third line of defense is specific. Okay? And in our case study earlier, you know, when you see a low white count and an increase in those lymphocytes, it gives you clear direction that this is most likely a viral infection. So the doctor will know that and he will be able to treat it accordingly. If we would have had a really, really high white count, a lot of times that's an indicator, and increased neutrophils, that's an indicator that it is a bacterial infection. That's why we want to know this stuff, guys. This is really the tools, along with, you know, physical and history, along with knowing what's going on with your patient, listening to what's been going on, and then doing these lab tests, doing these MRIs, ultrasounds, all these things are the things that doctors use to put it all together to be able to diagnose, treat, and monitor their patients. So now moving on to the third line of defense, this is an adaptive or acquired immunity. Okay, so again, guys, you can look in your textbook on page 182, 183, it lines out the first line, second line, and third line of defense, okay? That third line of defense is activated when the first 2 lines have failed to bring the invasion under control. It is the quote-unquote intelligent identification of the invader based on its antigenic properties. Then the T cells and B cells work together to produce a specific antibody that will destroy the invader or render it harmless. Okay? So specific, adaptive, or acquired immunity, right? Like I said, quote-unquote intelligent identification, right, of that invader on that antigenic properties. Okay? So for example, the antibody to strep does not work against pneumonia, and that's like I told you, it's specific to strep. Okay? So how does the third line of defense work? There's some great photos on page 183 that really go into this. So the T cells and the B cells work together specifically to destroy the invader or render it harmless, right? They're also capable of developing memory so that a second encounter with the same organism will induce a heightened and quicker immune reaction. So T cells or T lymphocytes, they provide that cell-mediated immunity, okay? That cell-mediated immunity, because they become involved at the site of the invasion where they become activated as they receive an antigen presentation from the macrophages, okay? So of the lymphocytes circulating in the blood, 70 to 80% are T cells. T cells become involved at the site of invasion where they are activated after they receive that antigen presentation I talked about from the macrophages, right? That's why when you talk about HIV patients and how they end up getting these strange diseases that we just don't see in the general population and they make them very, very sick, is because their T cell count is almost non-existent, so they have none of this to have any type of immunity against this stuff, right? Okay, so you got to think, when you have your T cells all flowing around in your blood, they have came in contact with different kinds of diseases out there, and we don't get sick from them. because we come in contact with them, we don't really get sick, but our T cells build up that immunity, that cell-mediated immunity to it, so then if we come in contact with it again, it just constantly fights it off. But then when all your T cells are decimated down to zero, then you just have no defense against anything. That's why we would see a lot of HIV patients come up with really weird and strange cancers and parasites and bacteria that we just didn't see in people their age. So once activated, those T cells rapidly duplicate themselves into clones that differentiate into 4 different subgroups. Okay? So as I talked about earlier, we have those killer T cells or cytotoxic cells. They're antigen-activated lymphocytes that attack foreign antigens directly and destroy the cells that bear that antigen, right? So we got TC, T8 cells, cytotoxin cells, right? Directly attack that foreign antigen and destroy it. The cells that bear that antigen. Remember, 8-year-olds like to kill things. 8, right? T8, right? Okay, then we have those helper T cells. Okay, those helper T cells, which can also are Th4 or CD4 or T4, right? They stimulate other T cells and help B cells produce antibodies. These cells are counted to see the damage HIV is doing to the immune system. The lower the T cell count, the harder you're being hit by that HIV disease. Remember, 4-year-olds like to help. T4. Okay, these are just little tricks to help you study this stuff. I know it all starts to run together. Remember, there's a lot of great information in your textbook, page 182, 183, with some great photos, just like this one here, that kind of shows you how all this is put together and how it works in the system. So we talked about, we had 4, right? We talked about 2, killer T cells and helper T cells, right? So we're going to move on to suppressor T cells, TS. They inhibit the T and B cells after enough cells have been activated. Okay, so we got to have something that says, okay, we've gotten everything we need. Don't just keep proliferating, just keep making them, because we don't need that, because then that could turn into a situation such as cancer, right? We don't want to keep doing that. And then we also have also those memory T cells, right? Okay, so memory T cells, remember the antigen, they are memory, right? Remember. So they're the ones that remember that antigen for the future encounters, right? They are ready to respond with any subsequent exposure you have to that specific antigen and have a much faster and more intense response to it so that you don't get sick to begin with, right? So here's a little quiz. Get a piece of paper. You can pause this right now and start answering each one of these. Okay, so like I said, the good thing is y'all can pause that, rewind it, and you can look at those and make sure that you can answer those, right? Here's another one of our critical thinking slides. What are the names of the 2 main types of lymphocytes involved in the 3rd line of defense? So again, guys, pause this and make sure you're getting this and that you can answer these questions, okay? Okay, so if a person with AIDS has a low T4 count, would this affect the T cells, B cells, or both? Both, right? And why would that happen? Remember, the T cells are helper cells, right? They not only stimulate other T cells, but they help B cells to produce antibodies. So without them, you can see where this would be a big problem for not just your T cells, but for your B cells as well. Okay, still on our third line of defense, which is adaptive or acquired immunity. Now we're going to move on and we're going to start talking about B cells, okay? B cells are involved in humoral immunity. Humoral immunity begins with the interaction of a B cell with a specific antigen and the lymphokine chemicals, those are chemicals, lymphokines, from the T helper cells, okay? After it is activated, it rapidly duplicates into a clone and differentiates into some subgroups, okay? So humoral immunity always begins with the interaction of that B cell, right? And like I talked about, that lymphokine is a small piece of antigen, okay, a little chemical, right? And then from the T helper cells, once it's activated, B cells, like I said, rapidly clone into two different groups, right? So we have plasma cells, right? And this is all in your textbook as well, page 183. Plasma cells produce the antibodies, immunoglobulins, that travel through the blood, specifically targeting and reacting with the antigens, resulting in the destruction of that invader, right? And then memory B cells remember, right? The antigen for future encounter. They also are ready to respond to subsequent exposure in the specific antigens with increased speed and intensity. Also remember classes of antibodies, immunoglobulins. Biomedical research have found that antibodies are part of the globulin group of proteins that circulate in the blood. Because of their globulin properties, antibodies are referred to as immunoglobulins. So that's why that's where that name comes from. Okay? So pause the slide and you can go through answering these questions. Okay, and here's another one of our case studies. So remember, you want to read this and you want to take everything you're reading into consideration, okay? Okay, so this patient comes in, male, female, young, old. We want to use all that knowledge we have, right? What's their previous history? What's their family history, right? They present to her doctor with a headache, malaise. Do you know what malaise means? Nasal congestion, and pain and tenderness and swelling over her sinuses. She had a low-grade fever, so the doctor ordered a CBC, which showed a moderate increase in WBCs and an increase in the neutrophils. So now from what we've learned and what I've talked to you guys before, what type of infection does she most likely have, bacterial or viral? Bacterial, right? Because you got a moderate increase in that WBC count and those increased neutrophils, which leads you to the bacteria route versus the viral route, right? So you want to name the two main types of lymphocytes that have been activated by this illness. T cells and B cells, right? Which of these groups produce plasma cells? The B cells, right? So we know what our antibody is. What's our antigen? Bacteria causing the infection, right? Okay, here's another one of those things I want you to fill in on your paperwork, right? You want to be able to describe concepts in your own words, right? So you need to be able to describe in your own words, because when you can do that, it means that you understand it and can relay that information properly, right? You want to do the difference between non-specific and specific defense mechanisms the body has in defending itself. Include how the first, second, and third lines of defense work. So that's all what you need to put down there, right? And you want to make sure your answer contains that non-specific defense mechanisms work against all foreign invaders in the same way. Specific defense mechanisms only work against the foreign invader they were formed to work against. Remember, you want to note that your first line of defense is stuff like your skin, mucus, coughing, and sneezing. They work non-specifically against all invaders. You want to know that your second line of defense is WBCs, neutrophils, monocytes, lymphocytes, and plasma proteins like interferon and complement. And inflammation work non-specifically against all invaders, right? Then you have that last and third line of defense. That's those T cells, a killer, helper, suppressor, and memory, and those B cells in the plasma and memory that work specifically against a specific antigen, right? So, ways to acquire specific immunity. Once a specific antibody is present in the blood, the individual is said to be immune, right? That's why having antibody tests for COVID-19 is important, because it very well, we don't know this just yet on COVID-19, but if they have those antibodies in their blood, then it can mean that those people are immune to COVID-19, which we hope that they would be. To its particular, like I said, particular disease, pathogen, and antigen, if it was COVID-19 or the flu or whatever. Measles, mumps, rubella, right? Specific immunity can acquire in 4 ways, right? So again, make sure you're following along in your textbook, because it really goes into depth about your active, passive immunity, okay? It also goes into the classified immunoglobulins that we have, the IgE, IgM, IgG, IgA, and IgD. Okay, so active long-term immunity acquired naturally. That means you contract the disease, right? You contract the disease, you build an immunity to it, right? Okay. Active long-term immunity acquired artificially. That's when you receive a vaccination, right? And earlier I said we don't want people to have to get sick to have immunity. Why? Because you could die from that specific illness. You could be left, in this case of polio, crippled. You could be left with lung damage, heart damage. There's lots of things. No, every one of these things that we take our vaccinations for, no. A lot of them are almost non-existent in the States, especially we've eradicated smallpox, but no, not every one of them kill. And COVID-19 is not going to kill everyone that gets it, but it can. We don't even know yet the long-term damage to the people who have been infected with COVID-19. That's one of the things I try to get people to understand that aren't in healthcare. They say, well, the flu kills a lot of people. Yes, I understand that, but we know a lot more about the flu than we do about COVID-19. It's too early to tell whether these people that ended up really, really sick, if they're really going to 100% get better. What if they're left with lung damage afterwards? This is why we cannot treat this virus just like it's the regular old flu, because we don't know enough about it to know if we're going to just heal up afterwards, or if we're going to be left with any specific long-term damage. Okay, so we're moving on our acquired specific immunity. We have passive short-term immunity acquired naturally, okay? So that's like when your babies are born. It is so much better if possible, and we need to do such a better job in the States to promote this and to help mothers do this. Mother's breast milk is the best thing for the baby, because they receive antibodies through that breast milk that can help them have a short-term, naturally occurring immunity to help them get through those early years when they really have no immunity, right? It also can happen through the placenta. And it's short-term, but it helps fill that gap for those babies so that they can get a little older before they can start building up a more active, a more active immunity through their vaccinations that they don't get when they're first born, right? And then we have that passive short-term immunity acquired artificially. You can receive anti-serum with antibodies from another. And that's something that we're looking at for COVID-19 as well, is to get the plasma from people that we know were infected with COVID-19, take those antibodies, and maybe have some short-term artificial immunity for patients out there. That's one of the things I know researchers and scientists are looking at. So right here, we looked at this, right? We have at the top, you see this, active long-term, right? Naturally and artificially, right? And you see this baby with chickenpox, which we don't have to do this. We don't need to have to do this, right? Active natural contact disease and produce memory cells. Then we have the better choice, which is active artificial, where you receive a vaccination and produce memory cells from there, and your child never has to get sick. So there's not a possibility of scarring, long-term issues, and possibly even death in some cases. Okay, and then we have that passive short-term immunization, right? Defense, right? Passive naturals, where we receive it maternally, antibodies through either the placenta or our breast milk. And that's why breastfeeding children is something that the U.S. really needs to step up. We need to make it easier for women to breastfeed their children. We need to promote that more. We need to have more breast specialists in hospitals and to help mothers get through the process. Now, not everyone's going to be able to do it, and there's no shame in that. But you should try, and we should give those women all the help they need to be able to do that. And then also on that passive section is that passive artificial, where you receive that antiserum with antibodies from another host. And like I said, that's one of the things that researchers are looking at now with getting this plasma from patients that were infected with COVID-19 that had built up antibodies to it. And this may be a possible way to give passive short-term immunity to our most at high risk patients out there, like our elderly or our people that have underlying diseases like COPD or heart disease or things like that. So still talking about on ways to acquire specific immunity. So what is the difference between active immunity and passive immunity? Okay, so active immunity is a long-term protection against future infection because the individual is exposed to the antigen, and the antibody they form is remembered in the memory B cells, making the individual immune to further encounters with the same pathogens. Now we're learning, and hopefully we always learn. You know, that's the key, is to never stop learning, never stop growing. Don't be afraid of change. When we find out that what we used to know doesn't work any longer, or that's not actually true, we shouldn't be scared to say, oh, eureka, you know, at the time, this is the information we had, this is the technology we had, so what we knew was this, and now we've learned that we need a booster, you know, and that's what I'm getting at. We have found out now that there's a lot of things that you were immunized against as a child that they are not forever, right? And this says long-term protection. It doesn't say forever protection. So there's a lot of immunization vaccines that we've gotten as a child that we really should keep up with, making sure we get our booster shots, right? Because that's not only the right thing to do for us, but the rest of mankind, because we want to keep that herd immunity up so that we don't have an issue with that in the problem. So that's what that active immunity is. Now that passive, remember, that's short-term protection, right? It gets us through a gap. Like this is really helpful for babies, newborn babies, because they're too little to get a lot of those immunizations and vaccinations that they need to make sure they don't get polio and measles and mumps and rubella. But they can get that passive immunity from the mother, through the placenta and through her breast milk, right? To give them just that area of time so they'll have a little bit of immunity to protect them until they do get old enough to have their vaccinations. And also, you think about this, while the whole COVID-19 thing is going on, if we could take plasma from people who had already been exposed to COVID-19, got well, moved on, and they had built up that antibody, and they had that antigen antibody in their plasma, and then we could take people in nursing homes and give them that, to give them some passive immunity to help them when we reopen the country, so that they will have a little protection until we can come out with a vaccine. That's why that's vitally important right now in that COVID-19 situation. So this would have been a collaboration activity that we would have done in class. You know, we would have done this. And this is a fun activity. I know you guys are at home, you're bored a lot of times. Play this game, pause this and play this and see if you can get these right, okay? So, you know, you receive a flu shot. Which one is that? Is that active natural, active artificial, passive natural, or passive artificial? Okay, so I'm going to help you with this first one. So you received the flu shot, right? So that's not natural, right? You got something, you know, that caused that. But it is a very active one, and it'll last for a longer period of time. So that's number 2, active artificial, right? Okay, so you guys go through these, okay? So a patient in your office receives an IV of antibodies, right? That is them receiving something. They didn't make it themselves, right? They didn't get it through the natural way, right? But it's passive artificial, right? Because those type of antibodies aren't going to last forever, but it could protect a patient in a nursing home from something until we are able to come up with a vaccine, right? Your son or daughter has measles. So they get around somebody that has measles, they contract measles, okay, and then they build up an antibody to it so that the next time they come in contact with measles, they don't get it. So which one is that? That's the active natural, right? That's the active natural, because you just naturally came in contact with it, naturally built up an immunity to it, and it lasts for quite a long time. And then we have, it's passed on resistance for some cold germs to my child before she was born through the placenta or breast milk, right? This is only short term, right? But it is natural because you passed it on to your child. So that would be passive natural, okay? And don't underestimate the importance of these passive, artificial, and natural defenses, because that baby really can use those passive, natural defenses to help them fill that space until they can get their immunizations. It's crucial. And think about if we could come up with right now, as we're looking to reopen our country, right? How great would it be if we could give any of our elderly, any of our nursing home patients, this passive artificial IV of antibodies from patients that were infected that would for a short time give them a defense to this until we can come up with a vaccine. How great would that be? Okay, so classes of antibodies, immunoglobulins, right? And remember, we talked about this over and over, right? But the more you say it, the more it's going to stick in your mind, right? Antibodies are part of that globulin group of proteins that circulate in the blood and are referred to as immunoglobulins, Ig, right? So how are immunoglobulins classified, right? Immunoglobulins are classified into 2 groups based on their shape, location, and function, okay? So here, and I told you about this, and this is on page 184 in your textbook too. So you want to name the immunoglobulins if given its function, right? So IgM is the primary responder, right? Like a medic, like a EMT, like a paramedic, right? Responder in the first encounter with an invading antigen, right? So that's IgM, medic, first primary responder, right? IgA. These are mucous membranes, right? That protects from bacterial and viral infection. Think about allergies, right? In your nose, right? Cause your nose to get stopped up, it swells up, right? Sneezing, coughing, right? And then IgD, right? That's involved in lymphocyte activation and suppression, downers and uppers, right? D. And then IgG, okay, so responds to the invading antigens in subsequent encounters. So it's the second guard, right? So you had the IgM, that's the primary responder in the first encounter, like the EMTs are the first one to get to them, the paramedic is the first one to get to them, M. But then on that G, that second guard, right? They are not on active duty, right? They get them on that second encounter, and then IgE is involved in allergic reactions. Think of E like EpiPen, right? And a study sets way to help you remember MADGE is MADGE, right? These are just little tips and tricks to help you memorize this stuff so that you can learn. So here's another one of our thinking questions. So make sure you pause this, get out your paper, and see if you can answer this question. Okay, so now we're talking about types of allergy testing, right? So we talk about these diseases, we talk about how everything works, because you need to learn that, you know? You need to know about all this and then move into how these tests work, because a lot of times how they work depends on how the whole thing works as a whole anyway, right? So immunology tests visualize a specific reaction between an antigen and its specific antibody. So what are the two types of immunology testing? We have in vivo. Those are immunology tests that take place within a large organism. An antigen is injected or pricked into the skin to see if the body has an immune reaction to it, which is seen as a red welt, that raised thing like we talked about on TB skin testing, right? As an example of that. And then we have in vitro. That's immunology tests that take place in a laboratory outside the body. Antibodies and antigens associated with disease are detected in the body fluids by mixing them with their specific antigen or antibody and noting the reaction. Chromatography are observed by color reaction. Okay, and you can see like some agglutination and things like that tell you. But you got the stuff that we do to your body, and we see if you have a reaction on your body, like that TB skin test. And then we have where you draw your blood, take your blood back to the lab, and we mix antigens with antibodies to see if we have a reaction, right? So CLIA-waived immunology test, right? CLIA-waived enzyme-linked immunoassays, right? So how do in vitro immunology tests work? So a liquid body fluid specimen is absorbed and travel across a testing area that enzymatically changes color if the antigen-antibody reaction takes place. An internal control must also turn color to prove the testing device is working. And so you'll see this little picture right over here. This is an in vitro pregnancy test showing the lateral flow immunochromatographic test method, right? So what happens is, you've seen this before, right? You follow the instructions and you drop the urine, which is usually what they do on there, and then the C is your control, right? And you wait, you read the package insert, you follow the directions, you wait X amount of time, and then you must always see the line in the control, right? That's an internal control that is responsible for making sure you know that that particular kit is working properly. If that control does not come up, then you cannot report those results out, okay? So there's a thin layer on there. So you see that area down the bottom, the little white circle down there. That's where you put your specimen, right? Usually urine. It soaks in and goes through that, looks like a thin tissue paper, and there's reagents in that, right? And it soaks through there. And if there's an antigen-antibody reaction, then that T is going to have a line come up, just like the control. so that you would report that pregnancy test out as positive. Okay? If the second one, number 3, right there, you have the control worked, nothing in the T, so that would be a negative pregnancy test. Number 1, if you did that one, you wouldn't report that one out at all. Why? Because the control area did not come up. So there's something wrong with either what you did and how you did it, or most likely there's something wrong with that particular kit, and you would need to get another kit and try it again. So still talking about those enzyme-linked immunoassays, right? So what do you call the type of immunology test where body fluid travels across a testing area that enzymatically changes color when an antigen-antibody reaction takes place, like the pregnancy test? That's a lateral flow immunochromographic assay, right? And you can see this, they talk about this on page 185 of our textbook, and there's some even more bigger detailed pictures that you can look at, okay? And this is a little better one. It's like I told you, this one can be before you even did the test, but if you did the test on number 1 and this is what you saw when the time was up, you would not report that out because the internal control did not work. But then once you put your specimen on it, there's your positive in number 2, there's your negative in number 3, and you're able to report those out because your control worked in both of them. So still talking about these CLIA wave testing. So we can name 9 different tests that use lateral flow immunology. You have your pregnancy. There's bladder, tumor-associated antigen, mononucleosis, H. pylori, HIV, fecal occult blood, which we saw that earlier, right? Same way, it had that, remember I said it's like that tissue looking like a material that's white, and the stool specimen goes on the back, and then you drop the reagent onto the front and you look for that color reaction. And also there's a built-in control on that, as there is in the influenza A and B test, the strep A, and different types of drug testing. So what is the difference between direct test kits and indirect test kits? So direct test kits provide the antibody in the kit and test for the antigen in the specimen, okay? So indirect test kits are the opposite, right? They provide the antigen in the test kit and they test for the antibody in the specimen. So in both cases, a color reaction occurs if antibody and antigen are present and the results are recorded as positive. If the color reaction does not occur in the test area, the result is recorded as negative. So you can see that if we wanted to see if that patient had an antibody to something, we could do an indirect test kit, right? Because it provides that antigen, and then you see if the antibody is in the specimen, if they have an antibody to that test, right? To that specific virus or bacteria or parasite. So here's one of our case studies. Make sure you pause this and read it. So we're still talking about CLIA wave testing, right? So what is the hormone used to detect pregnancy and where is it produced? So HCG, human chronotropic gonadotropin, right? It is produced by the chronic villi of the placenta of a pregnant woman, right? So when is that HCG first measurable in urine and blood? And when does the levels peak? So about 1 to 5 days after conception, you can actually measure the HCG that is in the urine and blood. And its concentration peaks at about, depending on the person, anywhere from 50 to 80 days after conception, right? And there's a little picture of that villi over there that produces that HCG, okay? So is HCG the antigen or the antibody? Antigen. If it doesn't say it's an antibody, it's an antigen. So how is this specimen collected for a pregnancy test? Because this is something we'll need to know, right? So first morning urines are the most concentrated, right? So if they're the most concentrated, that's when you would get the most concentration of HCG. So first morning urine specimens are really what we like to have, right? The urine specimen container must be free of detergents, and the urine should be refrigerated if not tested immediately. Once refrigerated, it must be brought back to room temperature by letting it sit out for about an hour prior to testing. So here's another picture of a different type of HCG test, right? So what are some points to remember when performing a pregnancy test, right? All right, you want to check your urine-specific gravity results. Levels below 1.010 may give a false negative result because of a diluted specimen. That's why we like to always use that most concentrated specimen first thing in the morning. If they drank a ton of water, it could dilute it out, right? You want to bring those test kits to room temperature prior to performing that test. And you always want to check your expiration dates and follow the package inserts to make sure that you are doing this test exactly how the manufacturer says it needs to be done, because they can vary from kit to kit. Okay, do not use the supplies or reagents from one kit with another one. Once you're done with that kit, if you have leftover pipettes, you leftover reagent, leftover anything, it just must get thrown away, okay? Because these kits have different lot numbers and things can change and you don't want to move them back and forth. Never assume the instructions, and I've went over this in class before, from different test kits are the same. As you know, whoever's ordering for your lab, that may not be you, and they may have ordered one test kit from one company one time, and then there was a sale on a pregnancy test kit that is from a different company, and they may do it slightly different. Or there may be a change to that kit from time to time, and you always want to take out that package insert from your brand new test kit and make sure you go over it, replace it. You're going to have a binder somewhere that you keep these package inserts. Take the old one out, dispose of it, put the new one in there. So you have the most latest up-to-date package insert from whatever kit you're using at that time. Qualitative test results will show negative or positive. You chart it as negative for pregnancy or positive for pregnancy, okay? Here's another one of our case studies, okay? So you can pause this right now and read it and start answering these to see if you're putting all this together. Okay, now talking about mononucleosis testing, right? So there's some information on page 186 in your textbook, okay? There's also a lot of great information on the different types of pregnancy tests out there and other stuff like bladder tumor associated antigen and things like that. So the causative agent of mononucleosis is the Epstein-Barr virus, EBV, right? Okay. So the infection is often called the kissing disease because it is transmitted by direct oral contact through saliva, right? Mononucleosis is an active infectious disease most frequently seen in children and young adults, okay? So clinical signs and symptoms are mental and physical fatigue, severe weakness, headache, fever, sore throat, and swollen lymph nodes, right? So an acute infectious disease frequently seen, right, in teens and young adults, okay? So how is mono diagnosed? We have three different ways, right? We have clinical symptoms that I told y'all about earlier, and you want to make sure you note these: the fatigue, the sore throat, swollen lymph nodes. You have hematological findings, increased reactive or atypical lymphocytes, and then you have immunological testing. It shows an increase in heterophile antibodies, the antibody to mono. And right down there at the bottom is that Quick View Plus, which is a test that you can run. It's going to be the same as other. It's that lateral flow, same as we talked about earlier. You put it in there, you're going to have an internal control, and you're looking for a positive or a negative, right? So, still talking about mononucleosis testing, when is the heterophile antibody first produced, and what percent of patients develop it within 3 weeks? So, it is produced by the 5th or 8th day after infection. So, for the first 5 to 8 days, you wouldn't test positive for mono, okay? But before the 5th day, somewhere between the 5th and 8th day, right after infection, 80% of the patient have a detectable level of heterophile antibodies within 3 weeks. In the 20% of patients who do not produce the antibody, the diagnosis depends solely on the clinical and hematological findings. So, FYI, the heterophile antibody is the name of the antibody specifically formed against mononucleosis. Most of the time, the antibody is not named, okay? So, there are 20% of patients out there that may have a negative test for mono, but they still actually do have mono. Okay, here's a case study. Please pause this, read through it, and see if you're putting this together. Here's some more questions having to do with our case study. Okay, on to another test, a CLIA wave test that you may do as a lab assistant or as a medical assistant. So, Helicobacter pylori testing, right? So, what is the causative agent of most, but not all, duodenal and gastric ulcers? Helicobacter pylori, or H. pylori, is a spiral-shaped bacteria, and it is the cause for most of those ulcers. It weakens that mucus lining of the stomach, and then the stomach acid penetrates the sensitive lining beneath the mucus layer, and the acid and bacteria then cause that ulcer, okay? And so again, I think it's like 90% of duodenal and 80% of gastric ulcers are caused by H. pylori. Okay, so what are some symptoms of ulcer, right? Because symptoms are something that we use together with our diagnostic tools to be able to diagnose our patients, right? That gnawing pain in the abdomen after eating and during the night. Symptoms are relieved by eating and taking antacids, right? Because it cuts down on that acid production in your stomach, which then it's not causing that sore inside your stomach. So how are they treated? Usually it's a little combination of things, antibiotics that kill the H. pylori and drugs that reduce stomach acid, along with usually you drink something that helps line the inside of your stomach. So what does the immunology test, how does that immunology test work? The test for the antibody to H. pylori, right? And there's a little thing right there that shows you a little picture of your stomach at that top over to your right, and then down at the bottom is picture of that testing that they do for H. pylori. And if you'll look in your book, they have lots of procedures that show you about how to do that quick view plus that we went over for the mononucleosis testing on page 190, 191. There's also a very interesting thing that you guys could look at. It's figure 7.6 on page 187, and it shows about this automated pregnancy test that I think is really cool. So then you can also make your way over and to page 193, and it's a much better picture of the different quick view and Unigold, these different this HI bacteria pylori testing, these CLIA wave testing, so you can see a lot of this and how it's done. So here's another case study. Like I said before, pause this and see if you're putting all this together. So now moving on next to human immunodeficiency virus, HIV. Okay, so the human immunodeficiency virus, HIV, attacks and destroys the WBCs. Remember we talked about our helper T cells, our CD4 lymphocytes, and the cells monitored with HIV, right? We lose our immunity. So transmission of HIV is primarily through sexual contact and shared needles with the infected person because it's a bloodborne pathogen, right? Remember, helper T cells protect the body against infection through cell-mediated immunity, right? They also help B cells produce specific antibodies through humoral immunity, okay? And if you look on page, the bottom of page 193 and page 194 and 195, it really goes through this Unigold HIV blood testing, exactly how it's done. It's really cool. And then, of course, you'll see up here the Aura Quick testing. They also show that on page 196 and 197 of your textbook with detailed descriptions on this. So you guys make sure you take a look at that. There's a lot of really good information there. So when helper cells are destroyed by the HIV infection, the body becomes less able to fight off infection and becomes more susceptible to opportunistic infections, right? So at what point after testing positive with HIV does AIDS occur? Because you know, HIV, you're positive for HIV, but that doesn't mean you have to develop AIDS, which is an acquired immunodeficiency syndrome. And it's defined by the presence of life-threatening infections and life-threatening forms of cancer, right? So when handling specimens for HIV testing, healthcare workers should adhere to OSHA's bloodborne pathogen standards, such as wearing appropriate PPE and disposing of contaminated materials in the proper place. But remember, we should treat everything, our reagents, our control samples, and all of our patients from babies to old people as they could infect us. Treat everything and everyone the same to protect yourself by making sure that you wear the appropriate PPE for the situation you are in and making sure that you dispose of your trash properly, okay? So how do reference labs test for HIV? So serum is used to detect the HIV antibody, right? And the enzyme-linked immunosorbent assay, ELISA, test is used first and is confirmed by the Western immunoblot method. So we run that ELISA method. If it comes up negative, then we don't go further. But if it comes up positive, we send it off to the Western blot to confirm that this is an HIV infection, right? So how do POLs test for HIV? So CLIA has now a waived HIV test that detects the presence of the HIV antibody. And you can see how important these CLIA waived tests are now. I mean, it is great to be able to quickly be able to see if you have the HIV antibody. Think if we would have from the beginning were able to come up with a test very, very rapidly that was a very good and accurate test that we could do quickly and efficiently to test people to see if they had COVID-19. So what type of specimen is used for the waived HIV test? Blood, or as you can see above, oral specimens are used. Aura Quick uses a specimen obtained by thoroughly swabbing the outer gums, both upper and lower. Okay? And like I said, there is detailed information on page 197, 196, and 197 about the Aura Quick test. Okay, so make sure you go over that. So here's another one of our activities and stuff. So make sure you read over this and figure out if you're putting all this together. Okay? Okay, and then moving on to fecal occult blood testing using IFOB kits. So how does the rapid immunochemical diagnostic test for fecal occult blood work? Okay, so the patient pierces a fecal specimen with the blue inner probe located inside the tube. After mixing the specimen with the buffer solution, it is mailed to the POL for testing or the testing lab, right? So these are some advanced concepts. Agglutination reactions, these are non-CLIA way testing, okay? So you want to describe an agglutination reaction. Agglutination occurs as a result of an antigen-antibody reaction that causes the visible, like when we do our blood testing, right? Remember we put our little drop of blood and anti-A, anti-B, and anti-D on our slide and we rotate it and look for agglutination? It's like that. So it's a lattice-like clumping together of blood cells or tiny latex beads, right? The reaction can be seen in a test tube or on a slide, and agglutination reactions are not CLIA weighed and must be performed in a hospital or a reference lab. So blood typing, ABO and RH, is determined by the agglutination testing. What are the 4 reasons for determining blood type? First of all, you want to make sure if they're having to get blood for surgery or for some other reason, say blood transfusion. You want to prevent hemolytic disease of the newborn, identification of parentage, see if that's the father of the child, and forensic or clinical evidence so you can see what blood type it is at maybe a crime scene, right? So how many different types of inherited blood antigens are found on the surface of RBC? More than 300. So why are the ABO and RH antigens the most important of these antigens? Because of the intense antigenic response with transfused to incompatible recipients. So in other words, a lot of those other ones you'll have very mild, if any at all, reaction to them, but the ABO and RH causes a very intense transfusion reaction that could cause kidney failure or death. So we always want to make sure we're matching up the proper ABO and RH. And you'll see a lot of this advanced concepts in our textbooks, page 198, 199. It goes into quite a bit of information. So how is our ABO blood type determined? By the presence or absence of A and B antigens on the surface of the RBCs, right? With individuals with A antigens are type A, and so forth, B's are type B, right? AB antigens are type AB, and if you have neither A nor B, then you are O. So Landsteiner discovered the ABO blood groups in the early 1900s. Okay, so what naturally occurring antibodies are present for the 4 blood types? So type A produces anti-B antibodies, right? Same thing with B, it produces the opposite, anti-A antibodies, right? A and B produce no antibodies, and O produces both A and B. So blood typing is performed to determine compatibility between a donor's blood and a recipient's blood. So what would happen if a patient was given the wrong blood type? Okay, if a blood antigen comes into contact with its corresponding antibody, the result is agglutination, clumping of the RBCs, eventually leading to hemolysis, which is breakdown of the RBCs. The clumped RBC blood cells cannot pass through the kidney, which may lead to kidney failure. It's not always deadly, but it can be. Okay, that's why proper identification of your patient, proper labeling of your tubes, never labeling any specimen until after you've ordered it, and paying strict attention to making sure that if you are running a test on somebody, that tube of blood you're running that test on matches up to that requisition that you're reporting those results out onto. It is vitally important, and it can be life or death. So what type is the universal donor and which is the universal recipient? So O is our universal donor and AB negative is our universal recipient. So to determine, how is the ABO blood type determined in the lab? So to determine the ABO blood type, the fact that specific antibodies react with specific antigens is the technology or the thinking behind what we do. So if anti-A agglutinates with the RBCs, the blood type would be type A. If anti-B agglutinates with the RBCs, then obviously blood type would be type B. If anti-A and anti-B agglutinate with the RBCs, then obviously A and AB, right? And if there's no agglutination with the anti-A nor the anti-B, the blood type would be O. Pause this, make sure you go through this and you understand this, so if you get a question on this, you'll know how to answer. So, determine the blood type of the following individual. Regina Taylor's RBC reaction with anti-A, but not with anti-B. So we're going to go through these, and I want you guys to be able to, because if you pause that previous slide and you've been studying this and you understand it, you should be able to answer these questions. Now I'm talking about the RH system. Okay, so how is positive or negative blood type determined? So those with the RH antigen, or D, on the surface of the RBCs are considered RH positive and comprise about 85% of the population. Okay, individuals who do not have the RH antigen or the D antigen are RH negative and comprise about 15% of the population. So most of the time, as you can see from these numbers, people you're going to be typing, if you were doing that, would most likely come up positive, right? So we want to talk about how those antibodies are formed in the RH system. So an RH negative person has no naturally occurring RH antibodies called anti-D antibodies. Anti-D antibodies must be induced after an RH negative person receives RH positive blood, or after an RH negative mother has an RH positive baby. So those are pretty much two ways that can happen if you are negative, right? So that leads us to hemolytic disease of the newborn and ROGAM, right? So hemolytic disease of the newborn, HDN, or erythroblastosis fetalis, is a hemolytic anemia. So you have jaundice and an enlargement of the liver and spleen in newborns. Cardiac failure, respiratory distress, and death often occur. It results from a mother who is RH negative, who forms the anti-D antibody after the birth of the first child. Remember, we got to come in contact with it first before we can build up what we see as a defense to it, right? So it results from a mother who is RH negative. She gets pregnant with an RH positive baby because the daddy is RH positive, right? So she builds up that anti-D to it due to the mixing of the baby's blood with hers at birth, right? So it doesn't affect her first child, right? Hemolytic disease of the newborn would not occur with that first child, okay? So how do we prevent it, okay? So now we know you're RH negative. We know your husband's RH positive. We know your baby was RH positive. We know you've had that baby safely, but those bloods have mixed and you want to have another child in the future. So how do we prevent hemolytic disease of the newborn? So with hemolytic disease of the newborn, you can prevent it by injecting the anti-D antibody, or ROGAM, during and after the pregnancy of an RH negative mother. ROGAM prevents the mother from becoming sensitized to the RH antigen. So here's one of our concepts, right, that we do for homework. So make sure you pause this and write this down, right? Because you've got to learn to do these types of things, to describe in your own words how RH incompatibility affects unborn babies, including firstborn and sequential birth babies, how the mother's blood type is connected, and how ROGAM works. Okay, so here's one of our case studies. Read through this case study and see if you can answer these questions. And again, if you're having any kind of issues with this, sorry about the phone, guys, make sure you reach out to me and let me know. Okay, so continuing talking about ELISA and quantitative analysis, okay? So, and guys, make sure you're following along in your textbook. You read your textbook. There's really a lot of really good information in here, okay? So, when are quantitative enzyme-linked immunosorbent assay, ELISA tests, most commonly used, and are they CLIA-waived? Now, why do we keep asking, are they or are they not CLIA-waived? Because you guys, if you are working in a physician's office lab, and you're a medical assistant or a lab assistant or even a phlebotomist, you will not be able to do these tests if they are not CLIA-waived, right? So for allergy testing, no. Okay, allergy testing are not CLIA-waived tests. Okay, so what does the term immunosorbent mean? It pertains to the attachment of an antigen or antibody to a solid surface such as a latex bead, and its wells in plastic dishes or plastic cartridges. Okay, and you see some pictures here, right? That give you an idea of that. And there's some more stuff in your textbook that'll help you out with this and kind of try to help you understand. It is more of a little bit of a complex system. But if you look at page 199 over to the far right hand side, it goes into these color change tests, these quantitative methods for indirectly measuring antibodies. And we really just want you to have an idea of it because it is a non-CLIA-waived test. So this isn't a test that you would perform unless you went on to become a clinical laboratory scientist. So how does an enzyme-linked immunosorbent, the ELISA test work, right? The antigen is fixed to the well, right, in a petri dish or some type of thing, right? And then the well is rinsed, and the serum specimen containing the antibody is added. The well is then rinsed to remove anything that does not bind. Next, an enzyme agent that will bind to the antibody is added, and the well is rinsed again to remove any enzyme that is not fixed. An enzyme color developer that will react with the enzyme is added. If the serum contains the antibody specific to the antigen, a color change will occur. The more antibody present, the darker the color. So then we go into titers, right? Because we talked about the more, the darker the color. And that's why we want to worry about that, because we can titer it out until we see, that it's no longer there, right? So a quantitative non-CLIA-waived method to determine the amount of a specific antibody in the blood, right? It is a test that measures the extent to which an antibody can be diluted before losing its power to react with an antigen. So you do these series of dilutions and the antibody is made. The weakest solution that still shows a reaction is what you report out. So you dilute it out so far and then you look for reaction. And so if you still have a reaction at 1/20th and then at the very next dilution you don't, so you report it out there, okay? And so this is reference and hospital laboratories perform both these agglutination and ELISA tests with moderately complex equipment to determine the quality of antibodies present in the specimen. Another quantitative method to determine that we just talked about is that titer, which is a quantitative test that measures the amount of antibody that reacts with a specific antigen, right? Quantitative antibody information can provide the physician with additional information regarding the extent of the acquired immunity. For example, a physician might order a series of Rh titers to measure the level of anti-Rh antibodies in an Rh negative pregnant woman's serum. The Rh antibody titer could then be used to monitor the degree of sensitivity the mother might be developing against her Rh positive baby cells during the pregnancy. So that's why it's important to use when we're talking about hemolytic disease of the newborn, right? Because the quantity of antibody in the patient's body is important when you're talking about a series of Rh antibody titers that monitor the degree of sensitivity the mother might develop, right, against that Rh positive baby cells during the pregnancy and may help with how much Rogaine needs to be given to her, right? So that wraps this chapter up. So we have the video for chapter 6 up, and now we have our video for chapter 7 completed. And remember, within the next few days, I'm also going to have up the videos for chapter 8. But remember, I've said this in the previous video, and I'm saying it in this one. I said at the beginning, I'm saying it now. You will have a test coming up, and I will let you know way ahead of time when that test is, and you're going to be given plenty of time to watch these videos, fill out your study guides, and read your chapters before that test is put up. And then that will be your last regular test, right? Then your next lecture test will be your final. Now, I will put up the videos for chapter 8, which you're responsible for. You need to read chapter 8, you need to watch the video, fill out your study guides and study it, but you will not have a specific test for chapter 8, but there will be questions on that final that pertain to chapter 8. So again, I miss you guys. I hope you're doing well. And remember, if you have any questions, comments, or concerns, please reach out to me. And remember, we talked about the immune process in this chapter, right? We talked about how to differentiate between cell-mediated humoral immunity. We talked about the 4 ways to acquire adaptive immunity. We talked about the classes of immunoglobulins. Remember, MAG. Okay, we talked about the principles of the vivo in vitro immunology test, direct and indirect test, and then we talked about performing pregnancy tests, mono tests, and H. pylori tests. We also talked about CLIA wave testing, right? And testing for HIV. So I'm going to quickly go through these slides, and then at the end, we're just going to end. We'll end at that. That way, that gives you a chance to go back over this. It's really a good way to study and stuff. But I'm going to say my goodbyes now to you guys. I hope you're staying safe and healthy. Hope everybody's doing well. And again, if you have any questions, comments, concerns about anything on chapter 6 or 7, please reach out to me. I'll be glad to help you. And be looking for those videos on chapter 8. And as soon as you read chapter 6 and 7 and watched the videos and filled out your study guides, when you get a chance, go ahead and start reading chapter 8 as well and filling out those study guides as well. Again, here's a review of what we've learned. These are really good slides that you can pause them, take out a sheet of paper, and just test yourself to see if you're putting all this together, if you're memorizing this stuff. All right, guys. So reach out to me if you need anything.